Hello, my name is Flavia Machado. I am a part of Global Sepsis Alliance Executive Committee and also a professor of clinical care at the Federal University of in São Paulo, Brazil. And it's my great pleasure to welcome on this section today, where we are going to discuss the impactful trials and innovative trial design on sepsis and COVID-19. We're going to have a wonderful 6 talks discussing the most important aspects on these trial designs and the best trials that we have. And it's my pleasure to first welcome on our session Professor Kate Rowan. Professor Kate Rowan is the director of the Intensive Care National Audit Research Center, known as ICNARC. She is an honorary professor at the London School of Hygiene, Tropical Medicine, and adjunct professor at Monastery University in Australia. Professor Rowan, after she got his PhD at the University of Oxford, founded ICNARC. ICNARC, for those who doesn't know, it is an independent, non-profit scientific organization which aim is to facilitate improvement in the structure, the process, and the outcomes and experience of critical care. The database of ICNARC now has more than 2.5 million of critical care admissions. And Professor Rowan is also deeply involved in many very well-designed and qualified studies. And she's going to tell us about one of these platform trials she's involved in, which is the adaptation that Remap-Cap run through during the COVID pandemic. Be very welcome, Dr. Rowan.
Thank you very much, Flavia, and good day, everybody out there. It's an absolute honor to be speaking at the World Sepsis Congress, so thank you very much. It's also been an honor to have seen the recovery trial and Remap-Cap up close during this pandemic, and I'm going to hear much more about that from many experts in this session. I should also say I'm very proud to be a member of the Remap-Cap family, and I've been asked to talk to you about the adaptation of the Remap-Cap trial during the COVID-19 pandemic. I'm sure we all remember this. The H1N1 pandemic, 2009, 2010. I'm sure there's a lot of people out there in the audience who can't forget the clinical burden that this also brought on critical care. Some of us also remember this, I'm sure, recently put together by Amanda Royak and colleagues. But what this showed us was that actually we had a lot of studies that were registered on clinical trials databases during the H1N1 pandemic, but only 73 patients were recruited into an interventional study, and no studies actually reported their results during the pandemic. So we sort of learned no information as we went through the H1N1 pandemic on how to treat patients with H1N1. So it won't surprise you, that learning led to the planning for the Remap-Cap trial. And this actually commenced in 2011, almost as soon as we came out the other side of the H1N1 pandemic. So what's Remap? What does it mean? It means randomized, because if we're going to evaluate interventions, we need to randomize. Embedded means that we need, when clinical practice is overburdened, capacity is full, that clinical care and research are almost as one, and we're learning while we're doing. Multifactorial, because we need to know about lots of different things, and an adaptive platform. And more of this as I go through my talk. Remap-Cap was first funded in 2014. The CAP stands for Community Acquired Pneumonia, severe acute respiratory infection, and it was funded as a work package within a much broader program of the Platform for European Preparedness Against Re-emerging Epidemics. So the purpose of Remap-Cap was to generate evidence that could be applied to clinical practice during a pandemic. the first patient with severe community-acquired pneumonia was actually recruited into Remap-Cap in early April 2016 in Utrecht in the Netherlands. But then this happened, and I'm sure we all remember this. So suddenly, Remap-Cap needed to step up and do what it had been designed to do in the interpandemic period, ready for the impending pandemic. So the first adaptation, if you like, was capped to COVID. So from community-acquired pneumonia to coronavirus disease. The next adaptation was, we were aware from earlier reports that critical care, intensive care, was going to be overwhelmed, and therefore the inclusion criteria of admission to an intensive care unit, as Remap-Cap had, wasn't going to suffice for the critically ill patients outside ICU. So that was changed to widen the scope. So another adaptation to including patients who were critically ill and receipt of critical illness organ support, to incorporate those critical care surge areas. And the last thing is, although mortality at 90 days, as we know, is the agreed best primary outcome for trials in sepsis, actually in a pandemic, you need something earlier, sooner, so you're generating the evidence sooner. And so we transformed this to a primary outcome of days alive and free from organ support at 21 days. And I'm sure you'll hear more about that in the session. So those adaptations were actually put together into a pandemic appendix that was added to the core protocol that was already in existence for Remap-Cap, so that Remap-COVID could be sort of seamless. And domain-specific appendices, or DSAs as they are here, the domain is basically a group of interventions that are evaluated together in a therapeutic area. And these were also rapidly prepared and approved. And much later, as you can see down there, Remap-Cap even extended its sort of areas from the severe or critical care patient into evaluating some domains to those patients with moderate COVID out on the ward. So what happened? Well, corticosteroids were already being evaluated in Remap-Cap, and that domain passed over into COVID-19. And you can see down the left here, months of the year in 2020 and 2021. And basically this sort of domains, these therapeutic areas with interventions in them on the right-hand side, slowly being adopted or adapted into the platform that is the platform trial of Remap-Cap or COVID. Corticosteroids, antivirals, immune modulation, immunoglobulins, statins, vitamin C, antiplatelets, etc. And as you can see, even as late as March 21, new domains still being added. So how does it work? Well, the reason it's multifactorial is that a patient with suspected or proven COVID-19 who is eligible to be in the trial basically is randomized into the available domains that are being run in a particular hospital and that they are eligible for. So in this case, I've an example of the antiviral, immune modulation, and therapeutic anticoagulation domains. And then the patient will be randomized to one intervention in the antiviral, one in the immune modulation, one in the therapeutic anticoagulation. So if you like, the patient is being evaluated for a regimen, a bit more like the care we give than just a simple A versus B parallel randomized control trial. So that's an important aspect of the multifactorial nature. So looking at top left here, patients are randomized into Remap-Cap, their outcomes are reached, and the trial data are recorded. And then at regular intervals, updated data are sent to the Expert Statistical Analysis Committee at Berry Consultants in the US, who are experts in these areas, who update the trial statistical models as formal interim analyses. And these were done greater frequency during the pandemic. The models are reviewed to see if any of the interventions have met predefined statistical triggers, superiority or efficacy, where an intervention is shown to be beneficial, inferiority, where an intervention is shown to be worse than the other interventions in the domain, or futility, where there is no benefit from the intervention. And for those interventions where the statistical triggers are not met, response adaptive randomization is conducted, and that weights the randomization proportions in favor of the interventions that appear to be more beneficial to patients. So it means that more patients will receive the more beneficial treatments earlier during the pandemic. What's happened in terms of results, and you're going to hear a lot about these today. The corticosteroid domain is closed. We had those wonderful results from the recovery trial, which you'll hear about, I'm sure, on dexamethasone, and that caused an analysis or triggered analysis on our corticosteroid domain. The antiviral domain, there were safety issues about hydroxychloroquine being used widely, and our regulatory agency paused for hydroxychloroquine in the UK in May, and then Kaletra was found to be futile later in the year in November. I won't say too much more about the immune modulation and the Tosi and Sari result, which, as you know, has been published, and Tony is going to talk later in this session on that. Convalescent plasma has been shown to be futile for the immunoglobulin domain, and more recently, therapeutic anticoagulation has been shown to be futile for those with severe COVID, but actually superior for patients with moderate or less severe COVID. All the other domains are open and recruiting. And because Remap-Cap is a global trial, while in the UK now we've got a bit of respite from COVID-19, we're well aware that other areas of the world are seeing the burden of COVID-19 still, and that allows us to continue to randomize into the trial. And of course, we can only go global if we have global funding. And here's just acknowledging and proud to say, as a UK person, our National Institute of Health Research also joining the sort of fold of funders for this really important trial. In terms of where are we right now, so this was accessed a couple of days ago, just looking at the middle column there, 6,224 patients have been randomized into Remap-COVID or Remap-Cap for COVID. And what's really interesting is that leads to almost 11,500 patient randomizations because of that multifactorial nature that people we're contributing to evaluation of more than one intervention in more than one domain. So it's an extremely, there's an economy of scale and efficient way to understand, as we say, as we deliver clinical care, to learn from that clinical care we're delivering. Just a little rah for Team UK. We had 12 sites open in Remap-Cap pre-pandemic, and I'm proud to say, because of the support that we had from our urgent public health branding from our government and our NHS, and our amazing NIHR clinical research network that helps us deliver research at hospitals in the NHS, we were able to go up to 143 sites, 46% of the global number of sites, and randomize over 4,400 patients, which was 71% of that global total. So I can feel as a Brit, although I'm sad to have Brexited, that we've at least done our bit for Remap-Cap. We continue to collaborate. There's a multi-platform RCT that's about to report on anticoagulation. We're collaborating with the Lovett trial on vitamin C, new regions, new domains all the time. There's a hydroxychloroquine meta-analysis, multidisciplinary experts joining us all the time, and also meta-analyses, one done on steroids by the WHO and one pending on the immune modulators, IL-6 receptor antagonists. So I hope I've done a little kind of run through the Remap-Cap and its adaptations for COVID-19. And please, 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 I'm just one of a large number of people in the Remap-Cap family, but please come and join us if you possibly can. Thank you.
Thank you so much, Kathy. It was a wonderful talk, and Remap is amazing. It's a wonderful thing that what you're doing. There were greetings for many parts of the world in the chat, but there is a specific question which is how do you evaluate for multiple interventions? I think most of the people are very curious about how you manage to evaluate for such multiple interventions that the same patient is suffering. And I would add to this question the issue of informed consent. Can you clarify for us?
So I am not a Bayesian statistician, and I will find it hard to answer the evaluation of the multiple interventions. But essentially, Remap-Cap should be seen as a large number of A versus B trials just within the sort of the same trial platform. So in the model, each intervention within a domain is actually compared with other interventions in the domain and the control, and then domains between domains are also for interactions are also evaluated. It's complex statistical modeling done by people who are well expert at that complex modeling, and I'm certainly as you move on to the presentation that Tony is doing on Tocilizumab, maybe Tony can explain a little bit more how those comparisons were done within the domain. In terms of informed consent, it's a global informed consent that's operated, and I think these trials are the trials of the future, and obviously you don't want to bombard patients with a multitude of different informed consent forms, so it's very much a consent form to sort of join the platform and to basically consent to have the domains they are eligible for to be randomized within them.
Perfect, perfect. Thank you so much, Katie. And let's go on with our next speaker, which is Dr. François Lamontagne. Dr. François Lamontagne is a critical care specialist and a clinician scientist at the University of Sherbrooke and the Center of Research of Sherbrooke since 2010. We all know all the papers and contributions that Dr. Lamontagne has done in the past few years, including clinical trials in resuscitation intervention and knowledge translation activities. And recently he was appointed as a co-scientific director for the Canadian Sepsis Network and the director of research in pandemics founded by the Research at Quebec Santé. François Lamontagne will tell us a little bit about the innovative trials to guidelines, how we go from innovative trials to guidelines, the WHO method. Be very welcome, François.
Thank you very much, Flavia, and thank you to all the organizers for this invitation. It's an honor to be with you today and present on guidelines work undertaken by WHO, or talk about the WHO method. Certainly from this disclosure slide, you'll understand that this is a bit of an outsider's perspective on the quote-unquote WHO method. Janet Diaz later on today will be presenting on behalf of WHO. But as you can tell, I've had the privilege of chairing a few of the WHO guidelines on therapy and prevention of COVID-19 during this pandemic. But my collaboration with WHO dates back long before the pandemic, notably during the various Ebola outbreaks. And I have been collaborating with many of Janet's predecessors, and in this situation was privy to a very noticeable change, a very positive change, which in my view is a bit of a revolution in its own right. And it is this change that I think should be celebrated, that I mean to talk to you about today. Oftentimes when asked to talk about guidelines work, the focus is on methodology, and it's obviously an important topic. It deserves to be mentioned that guidelines are there, have a distinct methodology. It's in a way design in its own right. But that's not the focus of the presentation today. It is important, nonetheless, to mention that a lot of the methodological principles that underline the creation of guidelines are sometimes in opposition. So, for example, you are expected to create a trustworthy guideline to rely on all of the available evidence. They have to be quite comprehensive, but at the same time, those guidelines have to be created very efficiently for them to be very relevant. So the bottom line is that it's hard to do all that, but something happened during this pandemic that made it possible. You've just heard a brilliant presentation by Kathy about Remap-Cap, a platform trial. So my own personal view is that what made this happen, what made the trustworthy, efficient guidelines possible, just like what made the embedded platform trials possible during this pandemic, is not, a new technology. It's not a new invention. The Remap-Cap, trial was designed before the pandemic. And similarly, there were a lot of very capable groups willing and able to create trustworthy and very efficient guidelines before the pandemic, but somehow the stars aligned during the pandemic, and it is about this alignment of the stars that I'm talking about today, and so from this outsider's perspective, my view is that this small revolution hinges on three main ingredients, largely thanks to the WHO leadership. My view is that the WHO took on a very proactive central coordination role, and that was crucial. The WHO relied on very valuable external methodological support to evaluate and report uncertainty, so to apply that methodology, and that was also crucial. And then the last part is perhaps the most important, but the WHO really injected a lot of global relevance in the area of guidelines, and this is also something to be celebrated. So I'll be sharing 3 examples that illustrate this personal view. And the first example has to do with the first guidelines on therapies for COVID-19 released by the WHO, the guidelines on corticosteroid therapy. Now, to put this into context, the pandemic was declared in March of last year, and as early as in June, the results of the recovery trial were released. So immediately, there was immense pressure to create a guideline based on the recovery data. But at the same time, there was, like I mentioned, pressure to consider data from a number of other trials that were still ongoing, including the Remap-Cap trial. And so in the years, before the pandemic, you would have had multiple groups releasing multiple guidelines at multiple time points, some quite early, some a lot later, and they could have, disagreed one with the other. In this instance, the WHO had immense, leadership and resolved to broker a win-win-win, situation where trialists, were sort of convened and asked to share data even before the trials were completed. So it was not so long that it was difficult to get consensus on sharing of data after the publication of the main analysis. This time around, trialists were asked to release data before a trial was completed. Journal editors were part of this discussion, meta-analysts and guideline makers. And the end result is a very desirable situation where everyone, receives academic credit for very valuable work, but the information, the maximum amount of information is made available to ensure that guidelines that are both very trustworthy and efficient are released as soon as possible to inform care globally. So that is really a game changer. We have to be thankful that there is a stakeholder with enough clout to broker such agreements in the global interest. The other example has to do with methodology a little bit more. I think we probably or underappreciated the amount of methodological input that is necessary in order to create very trustworthy guidelines. The methodology is there for two reasons. It increases the likelihood that the panel will get it right. Creating a guideline is very much a subjective process. You have you never have 100% certainty or 0% certainty. You're navigating in gray zones, and it's a judgment call. But the method allows you to increase your chances of getting it right and not having to update your guidelines and subsequently. Methodology is also there to help the panel explain how it came up with this decision in the end. It breaks down these very important underlying principles, and it allows the panel to explain why a subgroup effect was deemed credible enough to impact the recommendation or not. And therefore, if other people in the world disagree with this subjective decision made by the guideline panel, at the very least, they can understand and explain on which grounds they agree or disagree with a guideline. So that is quite important. And in this case, I think there was invaluable methodological input in these guidelines that have been produced and that are continuing to be released. And then the last point I thought I would make is perhaps the WHO's most important contribution. In a way, this was always very important for the WHO, but it wasn't as it didn't impact the guideline world as much as it is impacting the guidelines during this pandemic, and it has to do with global relevance. So up on screen is this drawing I just made up. So don't mind it's not to scale, but the numbers are correct. The numbers represent the relative risk for death in studies evaluating hydroxychloroquine for prophylaxis. And looking at this, you could say, well, the evidence is quite uncertain, but the guideline methodology stipulates that you should look not at the relative effects of an intervention, but at the absolute effects. These are more relevant. This is the information you should rely on. And immediately you can see the confidence interval is much, much narrower. The certainty is greater, and it's difficult to be much closer to zero than that. But a relevant guideline has to be very clear what you are rating certainty about. In this instance, the panel wasn't rating its certainty that there would be zero effect. The panel was rating its certainty on whether or not the effect, if any effect existed, was going to be important enough to impact a recommendation. Moreover, a relevant guideline has to consider not only one outcome, but all of the advantages and disadvantages associated with an intervention. That is what relevance is about. It would be a lot easier to just consider the p-value, but that's not what relevance is. A relevant guideline considers all of the advantages and disadvantages. And lastly, from a patient perspective, this is what these WHO guidelines are doing. They're taking, they're giving priority to the patient values and preferences, but values and preferences globally, from a global perspective. Now, understandably, values and preferences may vary around the world, but that is, what the panel is now doing under WHO leadership, is to encompass all of those values and preferences, which admittedly makes the work of the panel much harder, but makes those guidelines a lot more relevant globally. And hopefully this is something that, this is certainly a change for the better, and a change that will last after the pandemic. So whether or not you appreciate this, there have been a number of guidelines created in a very, very short time span, almost as quickly as data are released on steroids, remdesivir, hydroxychloroquine treatment and prophylaxis, and antivirals and ivermectin, and many others are coming. I suspect this will continue for as long as the pandemic rages, and we have to be very, very thankful for that. I would leave you on this last slide on a reflection and a question. And I certainly wonder what will happen after the pandemic. This is a massive undertaking, and whether or not the WHO maintains this effort in the long haul, we certainly should hope so. It would be certainly desirable to continue to make very methodologically sound guidelines very, very efficiently, but it would also be very desirable as other organizations get back in the business of releasing guidelines. These professional societies, that they take the same care WHO is taking to at least consider the global relevance of their guidelines. That is important for all of us. Thank you very much. That was all I had to say.
Thank you very much, François. A wonderful talk. There is a question here that I think is interesting. Could you explain a little bit more and give examples about what are the patient preferences and how we deal with this when we decide about the outcomes?
Sure. So, I mean, the patient, like, as I said, the decisions are subjective, and whether you're talking about certainty of the evidence or anything else, you're working on a continuum. And so, I mean, one thing to consider is that an intervention never has only benefits or harm. Oftentimes, there's a balance. I mean, take the case of, forget COVID for a minute. Take anticoagulation to prevent pulmonary embolism, or you have to consider the benefit, so the absolute risks of having a very bad event, something very bad happening to you, but you also have to consider the risks of causing harm with your intervention. And different patients may have different perspectives on these things. A patient who is quite young may be quite willing to, stay in the ICU for a very long period of time, regardless of the functional deficits that might arise. But someone later stages in his or her life might consider that this might be unwilling to pay this price. And so, values and preferences and how you attribute a different value to a different advantage and disadvantage balance varies a little bit. So the panel members have to put themselves in the shoes of most patients, and so they're treading a fine line and have to try to consider everyone's perspective, and so guidelines are reported in a way that explains how the guideline took into consideration what could be varying values and preferences. In general, strong recommendations are made when it is felt that the values and preferences are unlikely to vary a lot across different patient groups.
Perfect. Thank you very much, François. A wonderful talk. Let's go ahead and ask our next speaker to give his talk. This is Anthony Gordon. Professor Gordon is the chair of anesthesia and critical care at Imperial College of London and intensive care consultant based on St. Mary's Hospital. He's also the director of research for the UK Intensive Care Society and is chair of the Critical Care Experimental Medicine Group. He's a founder of the UK Critical Care Research Group, and he is the UK Chief Investigator for Remap-Cap, which was just addressed by Professor Kate Rowan. And he is going to tell us a little bit about Tocilizumab. Be welcome, Anthony.
Thank you, Flavia, for the introduction, and thank you for the organisers inviting me to speak. It's an honour to represent Remap-Cap today. So I'm going to talk about Tocilizumab in COVID-19 and other interleukin-6 receptor antagonists. My disclosures are shown here just to point out Roche and Sanofi provided the drugs to the Department of Health for free in the UK, but had no other input into the trial conduct. As I'm sure you all know, we see this severe inflammatory pneumonitis in the severe cases of COVID-19, and it's driven by many cytokines, and interleukin-6 is thought to be one of that is crucially important. And importantly, it is possible to block IL-6. In the case of Tocilizumab, this is a humanized monoclonal antibody that inhibits both membrane-bound and soluble IL-6 receptors. It's been licensed for over a decade now for treating rheumatoid arthritis. And more recently, it's been approved for the cytokine release syndrome that can be seen after CAR T cell therapy. And it was this idea of treating that led clinicians to potentially start using it, and in COVID. And one of the first reports, this one here coming out of China, is, I would say, a small case report where they gave it to 20 patients, who they described 15 of whom got better, or you could say 25% didn't get better. But their conclusion was this improved clinical outcomes and was an effective treatment to reduce mortality. I think many of us would suggest a 20-patient case series wasn't enough to change global care, and it needed to be tested in randomized controlled trials. And that's exactly what Remap-Cap was set up to do. As you've heard from Kathy about it, an international multifactorial adaptive platform trial for severely ill patients with community-acquired pneumonia that adapted for COVID-19. And as you've heard, it's a big global family represented by many little icons along the bottom, and it's a pleasure that I'm able to represent the group here today. So you've heard a lot about the trial, how it has multiple domains and multiple interventions. I'm going to talk about Tocilizumab and the other IL-6 inhibitor we tested, Sarilumab, within the immune modulation domain. And I'm pleased to say that the manuscript was published in the New England Journal of Medicine at the end of February, and you can see the full details, and including detailed supplements, so you can read all about the methods we used and the results. So the summary here, that for the sake of time, I will have to keep it brief, but to be eligible for the platform, we had simple criteria where you're an adult patient in hospital with acute illness due to suspected or proven COVID-19. The platform exclusion criteria is very simple, where you are actively dying and so on a palliative care pathway. Had you already been in hospital for 14 days because of COVID? And of course, you could only come into the trial once within a 3-month period. Then more specifically, we have inclusion-exclusion criteria for every domain and each of the interventions. And for Tocilizumab and Sarilumab, to be eligible for intervention, you had to have what we call the severe disease state, which was defined as being receiving respiratory support or cardiovascular support in an ICU. And that respiratory support was defined as either high-flow nasal oxygen, non-invasive ventilation, or full mechanical ventilation. And just to be clear, it was in an ICU, but accepting that many of us have had to extend into surge ICUs. So it was in a critical care environment. And the exclusion criteria listed here, I'm not going to say them all, but again, I think importantly, we tried to recruit patients early in their critical illness. It had to be within 24 hours of ICU admission or starting that organ support. We only excluded patients who were severely immune suppressed, who were neutropenic prior to the hospital admission. And of course, it was always left to the clinicians, if they felt it wasn't in their patient's best interest to be randomized, they should be excluded. The 2 active treatments we had were Tocilizumab, given as 8 milligrams per kilogram, maximum of 800 milligrams over 1 hour. And in this case, it could be repeated at 12 to 24 hours if the clinicians felt there hadn't been adequate improvement. There was also the possibility of randomizing to Sarilumab. In this case, it was just 400 milligrams given IV over 1 hour. And just to clarify, this is the subcutaneous preparation that was put in an IV bag. And it was open label, and so this control group received standard of care. Kathy mentioned our primary outcome measures ICU-free days, or more specifically, ICU respiratory and cardiovascular organ support-free days up to day 21. And just to explain this in a bit more detail, it's an ordinal scale and it's a composite endpoint. So it includes in-hospital death, which we deemed as the worst outcome, and that's scored -1 on this ordinal scale. And that is death at any time in the hospital, even after day 21. So that is the worst outcome. And then for the survivors, we count the numbers of days that they are alive and not requiring organ support. So a low number is bad and a high number is good. It meant they recovered more quickly. And again, you've heard a little bit about our design and the statistical model. Our analysis used the Bayesian cumulative logistic model. So the way this Bayesian analysis worked, you have a prior probability, and for the treatment effects here, we said they were all neutral. We generate the data from the randomization and generate this posterior probability of the primary outcome based on that data. And the way the model is constructed, we generate an odds ratio, and for all the results, an odds ratio of greater than 1 is good. That means there is more survival and or more days free of organ support. With this Bayesian design, there's no predetermined sample size. We keep randomizing with regular adaptive analysis, but we have predefined triggers for reaching a conclusion. And in summary, though, if the posterior probability was 99% probability that an intervention was superior to control, meaning if the odds ratio was greater than 1, we would declare stop randomizing and say that intervention worked. We equally have a futility stopping if there was a 95% probability that that odds ratio would be less than 1.2. At one of these adaptive analyses, our independent data safety monitoring report reported to us in November that Tocilizumab had met that trigger for efficacy compared to the no immune modulation, the control group. And as you'll see, it's 99.75% posterior probability that it was superior. So we then were able to analyze the data. By the time we actually followed those patients up and had now a larger data set to analyze, in fact, Sarilumab, the other IL-6 inhibitor, had also met the trigger for efficacy. So we can report that as well. And you see at that stage, nearly 900 patients. They at baseline were, as you would expect in a critical care environment, average age of around 60, more men than women, rather obese population. We recruited patients generally early in their hospital stay, the second day, and around 12 hours or so after their admission to ICU. And you can see around 29% were receiving high flow nasal cannulae, 40% or so non-invasive ventilation, and 30% fully mechanically ventilated. Their CRPs generally around 135, 150 medians. Just point out that the majority of these 900 or so patients that were treated were after June the 17th, after the steroid results first came out from the recovery trial. And as you see, the majority of patients were treated with corticosteroids, and around about a third of patients were given remdesivir as well. This is the primary outcome results, and the top line is the organ support-free days, which was our primary outcome, and you can see the counts here. Remembering a low number is bad and a high number is good. You can see the control group had a median of 0, whereas it's 10 and 11 in Tocilizumab and Sarilumab, respectively. But for the Bayesian model, which is our primary outcome, you can see the posterior probabilities here. You can see the odds ratios all clearly above 1. But the probabilities, therefore, they're superior, 99.5% in the Sarilumab group, and now the larger Tocilizumab group, more than 99.9%. For those of you who still may be unfamiliar with these Bayesian models, I would suggest you could look just simply at the in-hospital deaths, and you can see nearly 36% in the control group and 28%, 22.2% in the tocilizumab and saralimumab groups, respectively. If you like looking them on Kaplan-Meier curves, you can see them here on the left by the individual drug or pooled together for the two IL-6 receptor antagonists together. Clear survival advantage seen in those patients followed up to day 90. And looking at time to both ICU discharge on the left and hospital discharge on the right, you can see those patients treated with tocilizumab and saralimumab recovered more quickly as well. And the last bit of data and results showing for those patients who weren't ventilated at baseline, you could see there was less disease progression to need ventilation, ECMO, or death. It was nearly 53% in the control group, but 35 to 40% in those in the tocilizumab and saralimumab group. So it helped prevent disease progression as well. So in summary, we saw in this critically ill population who were receiving organ support in the ICU, when they were treated with IL-6 receptor antagonists within 24 hours, it led to improved outcomes, including survival. This led to immediate changes in practice in the UK, recommendations that these drugs be used in this sick population. And then I'm sure you'll be aware the recovery trial also reported a few weeks later that they had seen beneficial effects. In a sick group of patients, their criteria were patients who were hypoxemic, SATs less than 92 or receiving oxygen, and with a CRP greater than 75, with a clear mortality reduction, as we had seen as well. The Cochrane group have been looking at all the trials and done a meta-analysis. I don't have time to go through them all here, but you can see their conclusion. For all-cause 28-day mortality, there seemed to be this significant mortality reduction and the certainty of evidence rated as high. So why have not all the trials seen a benefit? I don't know. The two largest trials have seen benefit, so maybe it is just a power that comes with larger sample sizes. Nothing clever. Is it the use of concomitant steroid therapy? Both recovery and Remap-Cap suggest that, and I think that's being looked at in the WHO meta-analysis going forward. That may be important. You give both drugs. I think it's important we gave the drugs early in the disease process, and I think it's important not to give it too late. You want a sick group of patients, but not too late to treat them. And I would point out, importantly, none of the trials have seen any safety concerns, no increase in secondary infections, even if they haven't shown benefit. So I think we feel this is a safe drug to use. And so I will stop there and just thank everybody who participated, particularly the patients and their families who consented to take part in this trial. Thank you.
Thank you, Anthony. Great presentation. We have time for a quick answer, and we have a question, which is if you observe any increase in infection. And I add to this question, if you think that your results would be reproducible to settings where we have higher rates of nosocomial infection and higher rates of multi-drug resistance. Yeah.
We didn't see any increased rates of infection in our trial, and as I just mentioned, none of the other trials have found that in anywhere in the world. And I would put, importantly, that includes a trial from India that reported recently, where obviously things like TB are going to be far more common than they may be in the UK. So no increased risk of infection has been seen in any trials. I think people should be careful and look out for it. And remember that if they use CRP, that this will be lowered significantly by these drugs, and it may be falsely reassuring if there's infection. So people should monitor for that and be wary that the CRP may not rise if there is a secondary infection. And importantly, most of the trials have excluded anybody with an active bacterial infection. So select the right group of patients to treat.
Thank you so much, Anthony. Let's move on, because we are a few minutes late, to our next presenter, who is Professor Luciano Azevedo. Professor Luciano Azevedo is from the Critical Care and Emergency Medicine Department at the University of São Paulo. And he is also from the Research Institute at the Hospital Sírio-Libanês in São Paulo, Brazil. He is the former president of our Latin American Sepsis Institute, the former president of the São Paulo State Society of Critical Care Medicine, is the member of the executive committee of the Brazilian Research and Intensive Care Network, BRICNET, and he's a very good friend of mine. So Luciano will discuss with us corticosteroids in COVID-19, where we are. You're welcome, Luciano.
Thank you, Flavia. Thank you, my friend. Thank you for the organization, for inviting me to present our data and also to discuss on this very important issue of corticosteroids in COVID-19. So the title of my topic is Corticosteroids in COVID-19. Where are we? These are my conflicts of interest. I am one of the main investigators from the Brazilian Coalition COVID-19 group that investigates several drugs for treatment of COVID-19 patients. And we, as you can see in my presentation, we made a study on corticosteroids for COVID-19. And for this study, the Laboratórios Farmacêuticos Axê provided us with the drug and the insurance for the patients. If you want to talk with me about the issue of corticosteroids or being touched by one of these channels presented in this slide. So COVID-19 is a disease with several important patterns, and for instance, in the first 7 days of the disease, there is a mostly viral response phase when there is no significant compromise in the patient's lung, and after these first 5 to 7 days, there is the most prolonged host inflammatory response phase, where drugs that can improve inflammation, just like corticosteroids or Tocilizumab, may be useful for the patients with COVID-19. COVID-19 is also associated with increase in several cytokines with the so-called cytokine storm. For instance, interleukin-1 beta, TNF alpha, or interferon gamma may be increased in patients with COVID-19 which are critically ill. So this is another suggestion for the mechanistic standpoint that corticosteroids can be useful to reduce the inflammatory phase of COVID-19 patients. Also, during the ARDS phase of COVID-19, we can have significant impact of inflammatory response with release of inflammatory cytokines, with adhesion and inflammation caused by neutrophils at the lungs. So this can be modulated, this can be mitigated by corticosteroids during the early phase of ARDS caused by COVID-19. Also, corticosteroids might be important in the reduction of the fibroproliferative phase, the late phase of acute respiratory distress syndrome, which is characterized by increases in the production of collagen, also increase in fibroblasts, and corticosteroids also may be modulating this phase as well. The use of corticosteroids from the clinical standpoint in patients with respiratory diseases has been tried for several decades so far. This is the DEXA-ARDS trial, the trial with dexamethasone in acute respiratory distress syndrome patients, just published in January 2020, before the start of the pandemics. And the DEXA-ARDS trial showed that corticosteroids might improve the mortality rate in ARDS caused by non-COVID-19, caused by bacteria or other viral ARDS scenarios. So this led to the idea that corticosteroids could be useful for treating patients with COVID-19. The first major clinical trial that was published regarding the corticosteroids use in COVID-19 patients was the Recovery trial. Recovery was published in the mid of 2020, and Recovery showed that in patients with more severe disease, meaning patients hospitalized with COVID-19 using oxygen or high-flow nasal catheter or non-invasive ventilation or mechanical ventilation. The use of corticosteroids, 6 milligrams of dexamethasone, reduced mortality in these patients. Differently from patients without the need of oxygen therapy and hospitalized. In these patients, in recovery, the use of dexamethasone was associated with a non-significant increase in the mortality ratio. So this suggested that dexamethasone should not be used in outpatients and also in hospitalized patients without the need of at least a nasal catheter for oxygen replacement, for oxygen support. After the publication of recovery, the Brazilian study investigations of the Coalition COVID-19 Brazil trialists published the CODEX randomized clinical trial. The CODEX was a multi-center randomized clinical trial that was only applied to patients with moderate to severe acute respiratory distress syndrome. It had a design similar to the DEXA-ARD study, and we randomized 151 patients to dexamethasone and 148 patients to standard of care, and the intervention was to receive dexamethasone 20 milligrams intravenous for 5 days, and after 10 milligrams of dexamethasone intravenous for another 5 days, and the primary outcome was ventilator-free days up to 28 days. This was a study conducted in 41 intensive care units in Brazil, and we saw that the use of dexamethasone was related to an increase, significant increase in the number of days alive and free of mechanical ventilation up to 28 days. 66 days, 6.6 days at the dexamethasone group versus 4 days at the standard of care group with a statistical significance. We also collected data on the risk of adverse events with dexamethasone that recovery did not report at the time of publication. And we saw that there was no increase in the risk of adverse events with dexamethasone as compared to standard of care. No risk no increased risk on the new diagnosis of infection, ventilation-associated pneumonia, catheter-related infections, or also in the risk of increased use of insulin for hyperglycemia caused by dexamethasone. So this study suggested that dexamethasone is useful for treating, higher doses of dexamethasone are useful for treating patients with COVID-19 ARDS, and they are not associated with significant side effects in this group of patients. Together with the publication of CODEX, there was the publication of the Remap-Cap trial that demonstrated that hydrocortisone was associated also with an increase in the number of the days with organ support free in patients with COVID-19 and which are critically ill. When these results of recovery, CODEX, Remap-Cap, Cape COVID, and other studies were joined in the meta-analysis provided by the WHO RAP evidence group, this data suggested that the use of corticosteroids for critically ill patients with COVID-19 was associated with a reduction in mortality rates for these patients. So suggesting that corticosteroids are useful for treating patients with COVID-19. And WHO also published a guideline at British Medical Journal at the same time, emphasizing the recommendation of giving 6 milligrams of dexamethasone for all critically ill patients with COVID-19 admitted to hospitals all over the world. So there are still some unanswered questions. For instance, what's the ideal drug? A lot of people still uses methylprednisolone instead of dexamethasone, despite the fact that dexamethasone is the drug that we have evidence on it, that the studies were, the biggest studies were done on dexamethasone, recovery, and Codex, for instance. We still don't know what's the ideal dose. For instance, recovery use the same dose for a patient with several different disease severities, for a patient with a nasal catheter and for a patients on mechanical ventilation. So the ideal dose, should we use a dose, for instance, similar to the Codex dose for a most severely ill patient? What's the ideal time for the length of treatment for corticosteroids in COVID-19 patients? I mean, should we stop the treatment after 10 days, or should we prolong the treatment while the patient is still on mechanical ventilation, or the patient is still on the use of supplementary oxygen? And how about the weaning of corticosteroids? So there are several unanswered questions that need clinical trials that can provide us with these answers. With that, I thank you very much for your attention.
Thank you, Luciano. Great presentation. There are many comments in the chat, but maybe if you can speak a little bit more about why we should dexamethasone instead of methylprednisone or hydrocortisone, it's going to be good, because there are 2 or 3 questions on the same issue, which means which is the evidence for the other drugs and for dexamethasone. Maybe you can just speak a little bit more about this, because there are questions on this.
Yeah, sure. The major suggestion for using methylprednisolone for these patients with COVID-19 is that it's based on previous studies suggesting that methylprednisolone has much more lung penetration than other corticosteroids. But when these studies were done, they were not comparing methylprednisolone with dexamethasone. They were comparing methylprednisolone with prednisolone mostly. So we do not have a major comparison between methylprednisolone and dexamethasone. There was a small study, randomized controlled study, just published in BMC Infectious Disease, comparing methylprednisolone with dexamethasone. But this study compared different drugs and different dosages also. So it's difficult to, it's a very small study, less than 100 and something patients, and it compares different doses and different drugs. So it's very difficult to achieve a conclusion based on this topic. Probably the effects of corticosteroids in COVID-19 patients are related to the class, but not related to the drug per se. So probably methylprednisolone is also useful, and probably hydrocortisone is also useful for these patients with COVID-19. So the recommendation is for dexamethasone, because recovery was done with dexamethasone, and Codex was done with dexamethasone. So the biggest evidence were done with dexamethasone. But probably if you are without dexamethasone, you do not have the supply of dexamethasone at your service, you can use methylprednisolone or hydrocortisone with probably the same efficacy.
So thank you very much, Luciano. It was a pleasure to have you with us, and we need to move to our next speaker. So I have the pleasure to welcome Professor Peter Horby. He is Professor of Emerging Infectious Disease and Global Health. He is the former and the founding director of the Oxford University Clinical Research Unit in Vietnam. And back on Oxford on 2014, he established the Epidemic Disease Research Group at Oxford, the ERGO. ERGO is engaged in international programs of clinical and epidemiological research to prepare for and to respond to emergent infections. And now we are just facing one of these pandemics. So it's really a pleasure to welcome you, Professor. And you're going to speak for us about the implementation of the recovery platform in the UK. Be welcome, Professor.
Great. Thank you, Flavia. I hope you can hear me okay. So I was going to talk about the implementation of the trial rather than going into detail into the results of the trial. And so I'm obviously giving this presentation on behalf of the whole recovery trial team, which is a large team and a much larger number of investigators at the hospital sites. So I'd like to take you back to February, March last year when we were setting up the trial. We had already done some work in China. We'd started 2 trials in Wuhan, but those trials, whilst they had enrolled very quickly within 20 days of the outbreak being announced, they had failed to enroll enough patients because the very aggressive control measures in Wuhan brought the epidemic under control. And so we were then shifting our focus from China to Europe, because at that time Italy was really suffering very badly. And we started to design a trial for the UK. And what we'd seen in Wuhan and what we'd seen in China really gave us a very clear picture that we could be trying to run this trial in an unprecedented clinical context with very overstretched health services, limited availability of beds, staff and ventilators, huge time pressures and personal stress on the frontline medical staff, and potentially a very large number of unwell, anxious and often elderly patients. So that was the context. And then huge therapeutic uncertainty. We'd started trials of lopinavir, ritonavir and remdesivir in Wuhan, but not reached conclusive answers. And there were many candidate drugs being recommended, some of them rational, many of them irrational, many opinions being given, but no real reliable data on any of them. A lot of uncontrolled case series were starting to emerge and inconclusive trial data. So we really had a lack of certainty and a real dilemma for clinicians about what to do for their patients. So the principles that we sort of started with was that we must be very quick. Even though we'd started in 20 days in Wuhan, we'd only enrolled a couple of hundred patients into those trials, so really not big enough for a definitive answer. So we had to get out of the blocks really quickly if we were to capture the first wave in the UK. That we wanted to be big. We were unlikely to have a miracle drug. People who claim miracle drugs are generally not to be believed. We've seen years of treatment of severe respiratory infections, both with anti-inflammatory drugs, but also with antivirals in flu, and nothing very dramatic. So we should not design our trial based on a big win. But moderate benefits would be plausible and would be worthwhile. At the time we started the trial, there had been 1,500 deaths in the US, and if we could reduce mortality by 20%, by a fifth, we would save 3,000 lives. So really, when you've got a very large-scale health problem, then small benefits have a big impact. And so we were thinking about looking for a 20% reduction in the case fatality rate. I think some groups had powered their trials looking at 35, 40, 50% reductions in mortality, which we did not think was plausible. And so if we wanted a 20% reduction on a 20% case fatality rate in hospitalized patients, which is what early data were telling us in Europe, then we would need 2,000 patients per arm to have 80% power at a p-value 0.01. So we had to go big. And so if we're going to go big and quickly, it had to be simple. So we designed it to collect only essential data. And it had to be open label. We couldn't enroll those kind of numbers of patients quickly enough if we were trying to get placebos to all the sites and get them developed. So we went for objective and unbiased outcome, so that we reduced any risk of biases in outcome assessment. So simple eligibility, hospitalized with suspected SARS-CoV-2. Initially, we said you had to be confirmed SARS-CoV-2, but there was a delay in the early days in getting results through, so we went for clinically suspected, and it turns out that over 85%, 90% of patients were and still are SARS-CoV-2 confirmed when they're enrolled. Mortality as an outcome, unbiased, simple, and we could ascertain it both through deaths reported by the clinical trial teams, but also through linkage to national data sets. So very high ascertainment of the primary outcome. And also other important outcomes, use of ventilation, duration of hospitalization. Randomization assigned patients between suitable and available treatments. So if a patient was not suitable for a drug or the drug was not available, that would be marked prior to randomization in the system. And then patients would be randomized to the drugs that were both available and suitable. So it's important to note that all the exclusions are prior to randomization. so there's no bias there, and that all comparisons are only between controls who could have got the drug through the randomization process, so that they're a comparable group, and the randomization is concurrent, so all of the patients that are controls were concurrently randomizable to the drug that they were controls for. We had very simple consent form, 1 page, a very simple enrollment form, 1 page, and we started with multiple drugs, and we've evolved over time as an adaptive trial, and we went more into factorial designs, which have been very, very helpful. We've used a lot of data linkage, so we're in a luxurious position in the UK of having a National Health Service with extensive data linkage, and you can see here more than 15 data sets in which we have data linkage, and we have approval for data linkage for 10 years. So we can look at outcomes with a very high degree of completeness. So we have 99% completeness for the primary and secondary outcomes through linkage to national mortality data sets, hospitalization data sets, to Kathy's group, ICNARC, etc., etc. So we get very high levels of completeness of follow-up and primary and secondary outcomes. And we also now have linkage to primary care data, to renal and cancer registries, many information. We have linkage to the national COVID surveillance network, so we can also link through to genomics of the pathogen, etc. And this has allowed us to really simplify the trial, so it makes it very easy for the frontline healthcare workers to include patients. So we were really great in having a good regulator and a good ethics committee and a system in the UK where you can get national ethical approval through one committee. And so we submitted the first protocol on 13th of March, and we had regulatory and ethical approval by the 17th of March. And then 2 days later, we enrolled the first patient in Oxford, here in Oxford. So just 6 days from submission of the first version of the protocol to enrolling the first patient. And partly that was down to the fantastic committees, but also down to the simplicity of the trial. It was a very clear trial to begin with. And then the amendments have been very quick. So we added hydroxychloroquine. It was 2 days between submission and approval. Azithromycin 1 day. Tocilizumab was just 9 days. And the inclusion of children was less than 2 weeks between submitting that and getting approval. So that's really helped us to really go through the different drugs very quickly. So this is the timelines in the first wave. So we went to speak to the chief medical officer. I went to speak to the chief medical officer on the 10th of March and explain what we wish to do within the National Health Service. And that was a 15-minute meeting at which we were given the green light, said, yep, that sounds like what we need to do, just go ahead. And it was just 9 days from that meeting that we finished the protocol and enrolled the first patient. After 2 weeks, we had 1,000 patients. After a month, 5,000. And we had 10,000 patients at 56 days. So we really managed to catch the very early phase of the epidemic in the UK, which was fantastic, which meant that we captured the entire first wave and have been running ever since. This just shows you the breadth and scale of recruitment. So because of the National Health Service, simple protocol, simple contracting, we were able to open across the entire of the United Kingdom, and the green dots are the hospitals that are enrolling patients, and the size of the dots are the numbers of patients enrolled at each hospital site. And the graphic on the right is the enrollment in the first 100 days. The top line shows you that in 100 days, over 11,000 patients, or nearly 12,000 patients enrolled in the first randomization, which was the randomization that was steroids, azithromycin, hydroxychloroquine, etc. And then we introduced factorial randomizations. And so the second randomization is the Tocilizumab randomization, you can see, which we started after 40 days. And the red line, the bright red line, is the convalescent plasma, which we introduced once the NHS blood transfusion service had started to develop convalescent plasma for use. And this shows you, the enrollment. It really matches the epidemic curve in the UK. And at the peak of the first wave, we were enrolling over 400 patients per day. We thought we would never beat that, but unfortunately, we had a very big sort of second peak to the second wave. And during January, we were enrolling at one point over 500 patients per day. And throughout January, we enrolled over 10,000 patients. And you can see a screen capture there on the right that we've now got nearly 40,000 patients enrolled at 181 sites in the United Kingdom. And if you look at the tabs at the top there, you can see we've also opened sites in Indonesia, IDN, and NPL in Nepal. So we're going international now. Just to show it's very inclusive, this is the age at randomization graph, and you can see in the table on the right that the minimum age is less than 1, so we have infants enrolled, and the oldest patient is 103. So we're over a century in terms of our age span. We include pregnant women. We've got over 100 pregnant women included, and children as well, with 267 children involved. And we have a randomization for children that's both classic COVID, but also those with the multi-system inflammatory disorder. So we have a pregnancy and a pediatric working group who developed that part of the protocol. It is very simple. This shows you how long it takes to randomize. So the system collects data on how long it takes to randomize. So from the point that you click a button that you want to enroll a new patient to the time you click the randomization button and you get the result of what drug the patient is to receive, or drugs, the mean is 8 minutes. So it's just 8 minutes from deciding, opening the computer screen to enroll a new patient to actually getting the answer as to what to prescribe the patient. So really, the idea and what seems to have worked is really embedding the trial in clinical care. So instead of physicians having a choice as to whether they give off-label drugs, they could very easily enroll a patient and give treatment options through the trial. And we made it as easy as possible and could be done by any frontline healthcare worker. And this shows you the number of patients admitted by hospital. So you can see, some hospitals on the left in blue, 2,000 patients admitted, and on the right, 100 patients admitted. And the dots are the proportion at each of those hospitals of the patients recruited. And you can see on average, about 10% of all patients admitted to hospital in the UK were enrolled in the recovery trial. And what this has meant, that because it's large scale, it's efficient, we've got big numbers, a pretty clear endpoint, we can do a reliable evaluation of multiple treatments. And this shows you the drugs that have been or are in recovery and the numbers of patients on the active treatment. So 1,600 were on hydroxychloroquine, lopinavir, ritonavir, almost 6,000 received convalescent plasma, and almost 5,000 have received the Regeneron antibody cocktail, 2,000 each dexamethasone, tocilizumab. We currently have 1,500 patients randomized to baricitinib. We had 7,300 on aspirin, 2,500 azithromycin, and 5,600 on colchicine. So you'll see that the numbers are very different. So for the standard drugs, we've gone for about 2,000, but for the very cheap and easily available drugs like aspirin and colchicine, we went bigger because we wanted to see if we could detect a 10% improvement in mortality. And then for the antibody treatments, convalescent plasma and the Regeneron, we've increased that sample size because we want to be able to detect an effect in patients by their baseline antibody status. So to be able to detect an effect in patients who are seronegative at baseline. And so the results, you probably know about them. There's at least 3 drugs that were widely recommended, widely used, but have been shown to be ineffective: hydroxychloroquine, lopinavir, ritonavir, and azithromycin. Corticosteroids we've heard about was widely not recommended early on in the pandemic, and now is universally recommended. And tocilizumab, we heard from Tony, there was a substantial uncertainty, and together the 2 trials really have changed that, and it's now clear that tocilizumab in certain patients does have a benefit. The legacy really, this is a admissions board on an intensive care ward, and you can see that there's been a column added about which COVID trial the patient is in. You can see some are in recovery and some are in Remap-Cap. And I think the legacy should be that this kind of clinical trial is made easy enough that it can be done by clinicians on the floor very easily, so that we can offer options to patients, but also learn something and improve care as we go forward. And I hope we can take the learning from these kind of trials and use them in the future. So just to say thank you, that I'm one small part of this, and there's an enormous number of people, including particularly the healthcare and research staff and the patients who've been involved. Thank you very much.
Thank you so much, Peter. Unfortunately, we don't have time to answer all the questions that we have here, but maybe you can just answer a single one, which is how it's a wonderful platform. You're so it's marvelous. And maybe you can just quickly answer the question about the workload of the cleaning process of your database. And although you made it simple, I believe it's still a problem, isn't it?
We have a great team who do the data linkage. So we get all those linkage data sets every 2 weeks downloaded to us. And then we do have a team who link the data sets using NHS number. So you do need an identifier for the patient, so you can link the patient in the trial to all the data sets. And we have algorithms we go through to link the data, and we have rules. So if there's a conflict in the data, we have rules about resolving those conflicts. But what it does mean is all the work is at the back end, really, and at the front end of the trial, at the clinician-patient interface. It's really very simple, and I think that is critical.
Thank you so much, Peter. And we need to move on, and it's my pleasure to welcome Professor Tomoko Fujii. She is the leading investigator for the vitamins trial. Professor Fujii is an associate professor at the Jiki University in Tokyo, Japan, and he's working at the Jiki University Hospital as a specialist in intensive care physician as the direction of the intensive care unit. She has been collaborating in many investigator international multi-center clinical research projects, and she's going to speak about vitamins in sepsis, the good, the bad, and the ugly. Be welcome, Tomoko.
Thank you for the kind introduction, Flavia. Hello, I'm Tomoko Fujii from Jiki University in Tokyo, Japan. It's my pleasure to talk about sepsis trials in this World Sepsis Congress. My assigned title of presentation was Vitamins in Sepsis. However, we have only 10-minute slot, so I would like to focus only on vitamin C and sepsis. So let's get started. So the strong interest in vitamin C for sepsis took off in 2017 when a single center before-after study from the United States reported that a combination of vitamin C, hydrocortisone, and thiamine led to a dramatic decrease in mortality and rapid resolution of shock in patients with severe sepsis or septic shock. The biological rationale behind the vitamin C therapy is that patients with sepsis have significantly depleted vitamin C levels, and that vitamin C works as an antioxidant and a cofactor in the synthesis of catecholamines in the cell, which may help reversing vasoplegic state of sepsis. Most mammals are able to synthesize vitamin C in their livers, and the endogenous synthesis of vitamin C increases when the animals are exposed to stress. However, humans and guinea pigs have lost the ability to synthesize vitamin C due to the mutation in the responsible gene. So humans need to obtain sufficient amounts of vitamin C exogenously to prevent the possible fatal deficiency. Since the before-after study was published, more than 10 randomized clinical trials started to investigate if the observed effect could be proved in a higher level of evidence. And the vitamins trial was one of those trials. It was an international, open-label, randomized controlled trial conducted in Australia, New Zealand, and Brazil, aiming to determine whether the combination of vitamin C, hydrocortisone, and thiamine improves the time to shock resolution when compared with hydrocortisone alone. Patients with septic shock were randomly allocated to the intervention group or control group. Patients in the intervention group received vitamin C, hydrocortisone, and thiamine. In the control group, patients received hydrocortisone. Of the randomized 216 patients, 107 patients in the intervention group and 104 patients in the control group were included in the analysis for the primary outcome. The primary outcome was vasopressor-free hours up to day 7, And in the vitamin C cocktail group, vasopressor-free hours up to day 7 was 122.1 hours. In the hydrocortisone group, it was 124.6 hours. The median of all paired differences was minus 0.6 hours, and there was no statistically significant difference. There was no significant difference in all-cause mortality at 28 days or at 90 days after randomization. The numbers of patients who survived to discharge from the ICU or the hospital were similar between the groups. So the findings suggested that a treatment with vitamin C cocktail does not lead to a more rapid resolution of septic shock compared with intravenous hydrocortisone alone. And additional subgroup analysis was conducted to look whether there was any effect of early intervention. The first patient group in this table corresponds to a group who received the intervention within 6 hours of septic shock, because the vitamins trial had 2-hour window to identify vasopressor-dependent status, but there was no such signs of benefits in patients who received intervention within 6 hours or so. These findings in the vitamins trial were followed by their test trial. A test trial compared a combination of vitamin C and thiamine with placebo in patients with septic shock. The trial design was similar to that of the vitamins, aiming to cancel off the effect of hydrocortisone in the cocktail therapy. And the trial was conducted at emergency departments, which enabled the early intervention. And their test trial did not find any benefit with the combination of vitamin C and thiamine in SOFA score, mortality, or duration of vasopressor therapy. Most trials investigate the effect of the vitamin C cocktail compared to placebo or usual care. A randomized trial from China anticipated 140 patients, but the trial was stopped after 80 patients were recruited due to the increased adverse events of hypernatremia in the intervention group. With the available data, there were no benefits in mortality or duration of vasopressor therapy, but they reported greater decrease in SOFA score with intervention. However, the effect could not be attributable to the cocktail therapy, as we know that hydrocortisone play a certain role in shock resolution. Orange's trial was conducted in 2 ICUs in the United States, again, comparing the triple combination therapy with placebo. The trial reported shorter duration of vasopressor therapy, but no benefits in mortality or SOFA score. Unfortunately, the primary outcome was changed from mortality to vasopressor-free days after the trial completed the final follow-up. So changing the primary outcome after the trial completion to a statistically significant outcome inevitably raises a concern of selective outcome reporting. ACT's trial was published more recently, which also compared the triple combination therapy with placebo. 200 patients were sent to analysis, and the trial did not find difference in the decrease of SOFA score or mortality benefits. Victor's trial is the largest trial comparing the triple cocktail therapy with placebo. The trial was designed to recruit 2,000 patients, but was stopped early when they recruited 501 patients. The available data showed that there was no difference in vasopressor and ventilator-free days, and no benefits in all-cause mortality. So now that the vitamin C 6 grams per day is being investigated and the effect is not as eminent as was expected, so we need to take a step back and think about the dose. Because when we provide any intervention in clinical practice, we have to be sure that we're prescribing the right dose for the drug to take effect. So this is the phase 1 safety trial. The phase 1 trial focused on the safety of vitamin C in patients with septic shock. 24 patients were randomized into 3 groups to receive low-dose vitamin C, which was 50 milligrams per kilo per day, or high-dose vitamin C, 200 milligrams per kilogram per day, or placebo. Plasma vitamin C levels were suboptimal at entry, and they rose rapidly in the 2 treatment groups. Patients receiving vitamin C showed prompt reductions in SOFA scores in a dose-dependent manner, while placebo patients exhibited no such reduction. So the higher dose of vitamin C, which was 200 milligrams per kilogram per day, was suggested for further investigation. Then citrusali trial was conducted. 170 patients with septic ARDS were allocated to either high-dose vitamin C group or placebo group. The trial had 3 primary outcomes, which were modified SOFA score, C-reactive protein, and thrombomodulin. There was no difference in any of the primary outcomes. However, 28-day mortality was decreased with a hazard ratio of 0.55. But there were 46 secondary outcomes, so the mortality benefit may be a chance finding, but the finding is appealing for further clinical trials. So how far have we come? This is a network graph of the comparisons which data we've had. Steroids for septic shock has intensively investigated in many large trials, establishing its role in the shock resolution of septic shock. So the vitamins trial and a test trial controlled the effect of hydrocortisone in examining the effect of the combination therapy to find the null effect of the combination of vitamin C and thiamine. And what we can expect in the next 1 or 2 years would be the result of randomized controlled trials comparing higher dose of vitamin C with placebo in patients with sepsis or septic shock. Remap-Cap vitamin C domain is collaborating with Lovett trial in Canada, targeting COVID-19 related sepsis. So here are the conclusions of my talk. A biologically plausible rationale gives us hope and also passion, but we need robust data from clinical trials that are conducted rigorously before we implement new therapies into clinical practice. And answering a clinical question by clinical research is not a simple one-step process, as we've just reviewed the dose-finding study for vitamin C. And what we have come to know is that if vitamin C is given 6 grams per day, the mortality benefits are unlikely, and the effect on organ support is inconclusive, because many trials compared the mixed effect of hydrocortisone and vitamin C with placebo. And clinical trials with higher dose of vitamin C monotherapy are ongoing. So at this stage, clinicians should remain focused on appropriate usual care for sepsis, which should include prompt resuscitation with antibiotics and adequate source control. Thank you for attention.
Thank you very much, Tomoko. It was a very nice presentation and a very clear one. We have a question here. It is about the combination of vitamin C and zinc, and also a question about neonatal patients. If you can address them quickly, it will be great.
Okay, so interesting question. Thank you. There are a couple of trials, I remember, examining the effect of the combination of vitamin C and zinc, but the trial size were not sufficient to draw any conclusion. So I think we need more data or more clinical trials enrolling patients into those groups. So at this moment, we can't draw any conclusion about the combination with such micronutrients and vitamin C. And I'm not aware of sufficient amount of data including neonatals. But pediatrics trials have been started, so we may be able to see the results in the coming couple of years. I hope so.
Thank you very much, Tomoko, and thank you all. I believe we had a huge and great section, marvelous section, and certainly it helped us a lot to better understand what is going on in terms of impactful trials and innovative designs. Thank you for all the attendees, and thank you very much for all the speakers. And I also want to thank all of our sponsors for providing us the chance to give you this wonderful World Sepsis meeting. And I also want to ask you to follow us in our social media. Thank you very much.